Okay, good afternoon. We're going to go ahead and get started. Welcome to the 6th meeting on health services. We have a quorum, and I will have DJ go ahead and take the roll, and we'll get started.
Representative Bentley. Yes, sir. Representative Bratcher.
Here.
Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Duval.
Here.
Representative Frazier Gordon. Yes. Representative Justice. Representative Neighbors.
Here.
Representative Rayburn.
Here.
Representative Raymer.
Here.
Representative Riley. Here. Representative Rourks.
Here.
Representative Sharp.
Present.
Representative Wilner. Representative Whidden. Vice Chair Dotson.
Here.
Chair Mosier.
I am here. Okay, we have a quorum established to do business, so welcome again, everyone. Are there any committee members who have guests who you would like to introduce? I see Representative Riley and then Representative Bentley.
Thank you, Madam Chair. I'd like to introduce my good friend, Executive Vice President of T.J. Sampson Hospital in Glasgow, Kentucky, Stacy Biggs. Stacy, if you could stand up or wave to everybody. Thank you.
Representative Bentley.
Thank you, Chair Lady. I wanted to welcome all the pharmacists today, and especially Hannah Mikado and Robbie Larson. They're my interns from the College of Pharmacy, and also Mr. Wilson out there. You're all welcome.
Let's make them feel welcome. Representative Rourks.
Thank you, Chairwoman. I have with me today Caroline. She is the daughter of Sarah Cooper that many of you all know from the Cabinet for Health and Family Services. Please make her feel welcome.
Okay, well, thank you for being with us. And the first bill we are going to hear is House Bill 408. If Representative Shane Baker can make your way to the table and bring any guest with you that you have and introduce yourself for the record, and please proceed. And we do have a committee sub. So we have a motion on the sub and a second. All in favor of the sub? Thank you. Okay, please proceed.
Thank you, Madam Chair. I'm Shane Baker, State Representative for the 85th District.
My name is Josh Wesley. I'm the Acting Chief of Somerset Police Department.
Can you make sure that your microphone's on?
It was on. Just pull it.
Yeah. Josh Wesley, Acting Chief of Somerset Police Department.
Thank you.
I'm John Alexander. I'm Communications for Pulaski County Government.
Very well. The floor is yours.
Thank you, Madam Chair. House Bill 408 is born out of a situation we faced in Pulaski County. And as I've gone through this issue, I've learned it takes place in many other communities as well. An issue of people recruiting individuals from out of state, bringing them to the Commonwealth, putting them on Kentucky Medicaid in a drug treatment facility, and then when they're finished, they're homeless on our streets.
Motion on the bill.
Okay, we have a motion and a second on the bill. I will invite your guest to make a few comments if you'd like.
For us, of course, I was told a long time ago, once there's a motion on the bill, it's probably best to stay quiet at that point. But I will say that this is a basic ask for our local governments to say that if any of these recovery centers that do good jobs, people do find help in these rehab centers. But the basic ask is if that they bring someone from out of the community, especially out of the state, the basic human thing to do is if they don't make it in the program, for whatever reason, that they are able to find their way back home.
Thank you.
I would just echo what Mr. Alexander said as well. It's not that we're against rehabilitation, but as far as law enforcement is concerned, I came prepared with several different incidents that have occurred in our community that presented a significant risk to law enforcement, the community, all stemming from patients that are being brought in from out of state, wishing to leave the facility and then not having transport home, and they're turning to stealing vehicles, engaging in other crimes, and mostly just in an effort to try to return to the community that they were brought in from. So.
Okay. All right. Well, thank you. Any questions? Representative Bentley?
Thank you, Madam Chair Lady. When this happens, this bill will guarantee their transportation back to their home.
It primarily does two things, Representative Bentley. One thing is it requires transport back to their community. There's a couple different things they can do. They can get them a one-way ticket back home. They can contact their family and ask them to come get them within 24 hours. They can connect them with a mobile response team if available. But the other part of the bill is trying to ensure that they don't recruit people from out of state and bring them here and put them on Medicaid. There's some penalties for that.
Follow-up question. From your all's experience, are most of these people United States citizens?
It's been my experience that they are.
Yes.
Okay. Thank you, Madam Chair Lady.
You're welcome. Representative Wilner, do you have a question?
I do. Thank you, Madam Chair. This is an issue in my community as well. I'm sure it's statewide, and so thank you for your attention to this issue. I do have a question just about penalties. Mm-hmm. So if we've got, and this may not be in the substitute, so the committee substitute, so if you could help me with this. But my understanding is that we've got centers who are recruiting people from out of state, putting them on Kentucky Medicaid, but then the individuals who've been recruited could be required to pay penalties or to be charged with things. So I'm a little confused about that.
Thank you for the question, Representative Wilner. There was a couple fixes in the sub on that. So what we did is in the substitute, we moved that penalty away from the individual and over to the provider. So there's two potential penalties for the provider. One is for the act of recruiting, and the other is for having that individual in their facility. So it'd be $500 per day rather than on the individual. It's now on the provider.
That's very reassuring. Thank you so much.
Thank you.
Representative Burke.
Thank you, Chairperson. I also have a question. I want to echo Representative Woolner's support for the bill. I'm grateful to see this work being done and to prioritize Kentucky residents for our facilities. My question relates to the recruitment of out-of-state residents. In my experience as a social worker, I've seen people who have addiction issues, once they've burned all their bridges at home, they go find another place to burn bridges, so to speak. And so would this bill apply to a Kentucky-born and raised person who, having run the course of addiction here in Kentucky, then has fled to another state, and then they're being essentially brought home? They may have established residency in Tennessee or Indiana or somewhere else where they had fewer connections. Would the facility that they came to in Kentucky be subject to the same penalties? Would they be caught up in this net, so to speak?
Well, thank you, Representative Burke, for the question. So on this, if they've established residence elsewhere, if they've moved there and they've built a life somewhere else, they're essentially a resident of that state. So at that point, they would be an out-of-state resident. So I do believe it would impact them as well.
Okay. I mean, I thank you for that answer. That is really my only concern with this bill, which I'm broadly supportive of. I just know from experience that people do leave after they've exhausted their ability to exploit family here, but perhaps we wouldn't want to include them if this is the best community for them to return to gain sobriety. So I don't know if there's an opportunity to create an amendment that someone who has substantial connections here may not be subject to this provision or not. So thank you.
That's a great question, and I appreciate the concern on it. I'm happy to have the conversation with you and with others as well to figure that out, because I don't know if there's anything that defines, people that have moved and are coming back. So it's something we could look into.
Right. Yeah, I'll just make a quick comment. We've worked on this. We've talked about this, and not specifically that issue. So thank you for bringing it to our attention. We have worked to ensure that the Kentucky eligibility for Medicaid is well established. I'm not sure how to get around that issue. I mean, maybe we can have a conversation, but I don't know that that's something that we can solve in this bill. And then as far as the transportation, I felt like it was important to tie some of the potential transportation to the mobile crisis response team that we are establishing here in Kentucky and funding in the budget, because those are behavioral health experts and potentially addiction counselors and folks who can actually help tie the individual who's leaving either against medical advice or has had other issues in the facility and they're leaving. It'll just be an opportunity to tie those individuals to another therapeutic alternative. So we've tried to think this through, and I really appreciate your work on this. And thank you, gentlemen, for being with us today.
Thank you.
Okay. Do we have any further questions? All right. We'll see no further questions. DJ, please take the roll.
Representative Bentley,
Yes, sir.
Representative Bratcher,
Yes.
Representative Bray,
Yes.
Representative Burke,
Yes.
Representative Callaway,
Yes.
Representative Camuel,
Yes.
Representative Dotson,
Yes.
Representative Duval,
Yes.
Representative Frazier Gordon, Representative Justice, Representative Neighbors,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Rorks,
Yes.
Representative Sharp,
Aye.
Representative Wilner,
Yes.
Representative Whitten,
Yes.
Chair Mosier.
Yes. Okay. House Bill 408, as amended by the committee sub, passes with favorable expression, and the same should pass on the House. Congratulations, and thank you very much for your work.
Thank you, Madam Chair, and thank you, committee.
Thank you. Next, we will hear House Bill 477. Representative Neighbors will present, and just invite your guests to join you and introduce yourselves for the record. Make sure your microphones are on. And please proceed.
Thank you, Chairwoman Moser and committee. My name is Amy Neighbors, and I represent the 21st District, which includes Metcalfe, Monroe, Adair, and Cumberland counties. With me today, I have Ms. Deb Campbell, who is the VP of Clinical Strategy with KHA, and also Russ Ronaldo, who is the CFO with Owensboro Health. Today, I bring to the committee House Bill 477, a bill that will encourage the early identification and treatment of sepsis and to agree with the U.S. Centers for Medicare and Medicaid's coding classification system. My family has been affected by the damage that sepsis can do from the elderly to the young, and early treatment truly is successful to recovery. At this time, I would like to allow my guests to introduce themselves, again, if they would like, and to take a moment to further explain the importance of this bill.
As she said, I'm Deborah Campbell and work with KHA, but I think more importantly for talking about this bill,
Will you pull your microphone a little closer, please?
Yes.
Thank you.
Is that better?
Yes.
Okay. Yes, but more importantly for this, perhaps I've been a nurse for more years than I care to mention. I'm really thankful for the opportunity to share from a clinical perspective the urgency that we feel about this bill. Many of you may know that for every hour of treatment delay in a case of sepsis, the mortality rate increases by 7%. So the fact that sepsis is not a disease entity in itself, and therefore there's no diagnostic test that can be just quickly run, and it can happen to anyone. Two people with the very same illness from the very same organism, some people develop sepsis, some do not. So that very unpredictability makes this early screening absolutely critical to saving lives. And in fact, if we can catch it in the early stage, the mortality rate's 4%. If we do not, and the patient goes on to develop severe sepsis or septic shock, the mortality rate goes to 28 to 68%. So that's 1 in 4 people will die, up to 3 in 4 people will die. So we must catch it early. And that's the goal of this. So the change that we're asking, or the staying with the same process that we're asking for, is to continue to be able to do the early screening, which involves information that we have at the time our patients first present to us in the ER: heart rate, respiratory rate, temperature, whether they have an infection or suspected infection. Because if we wait and use the proposed or possibly being proposed change, we would have to wait until a patient shows signs of organ failure. At that point, stopping that runaway train becomes very difficult, if not impossible. I've talked about the mortality rate. I will just quickly mention those patients who do survive have to deal with so many complications that are almost impossible to imagine, like amputations, some patients of all 4 of their limbs, terrible cognitive deficits that make people who can never return to work, bad psychological processes like severe anxiety and depression. I've had people tell me that their family member has never been the same person again. So getting these patients screened and treated early will make the difference in their lives. And one last thing I'd like to mention is in 2021, we began a statewide sepsis consortium through the Kentucky Hospital Association. And over a very short time, we recruited all of our hospitals that have emergency rooms to be part of that process. Using this bundle that's called SEP1, that we've been promoting and has grown to almost 100% being done at the time of triage in the emergency room, we've decreased in-hospital deaths across our state from severe sepsis and septic shock by an average of 37 deaths per 1,000 discharges per month. So it works. So thank you, and pass it on to my colleague.
Thank you. I'm Russ Rinaldo. I'm the CFO at Owensboro Health. I also serve as the hospital tech chair, and I've had as many discussions on sepsis over the last few years as I want to. But from the financial side, the proposed change is to basically eliminate sepsis diagnosis, and an equivalent of refusal to pay for the care of sepsis. So Medicaid uses Medicare payment principles on how they pay for care, and Medicare does recognize sepsis. And if the change goes through, and so how Medicare pays it, they look at the condition or a procedure and they match up the resources that is estimated for a hospital to use to pay for that care. So an open heart case has one payment, a sepsis case has another payment. By eliminating sepsis, what's going to happen is that the payments these cases are going to be put into categories where that cost of caring for sepsis isn't. So instead of a sepsis case, it'll become a urinary tract infection or cellulitis. And in Owensboro's case, we would see about a $4,000 reduction in payment due to the proposed change, or about $400,000 a year. So it's and what Ms. Campbell talked about, she talked about how it's a disincentive for the early interventions. So when you look at, if you go back, Medicare put in penalties for readmissions. I never thought in a million years hospitals would not try to improve that. Look at their readmissions and try to improve it. But I have colleagues in this industry that don't chase it because the penalty is much less than the revenue cut from the readmissions that they're getting, and they can't afford it. And so it's almost similar to not paying for a mammogram unless you know breast cancer is there. So you're not paying for sepsis unless there's severe sepsis on the claim and organ dysfunction. It does nothing for patient safety. It does nothing for access. It does nothing for quality of care. This is just a proposed change to pay less and not pay for the cost that we incur to care for sepsis patients.
Motion on the bill.
Okay, we have a motion and a second on the bill. Do we have any questions? Representative Bentley.
When you're using the term here sepsis, are you talking about gram-negative sepsis?
I'm actually talking about all sepsis when I was looking at those statistics. So not just gram-negative, but any sepsis, which, can come from a bacteria, can come from a virus, it can come from even a fungus.
You're using the broad term
yes,
instead of
sir.
gram-negative.
Yes, sir.
To diagnose it, do you have to have a blood test?
To diagnose sepsis, to diagnose the infection that's causing the sepsis, usually use lactate and blood cultures.
So you have to have a blood test to diagnose like gram-negative sepsis?
Yes, yes.
So do you miss it sometimes?
I think the bundle that we're talking about that CMS first proposed, the SEP1 bundle, includes drawing a blood culture as part of this initial work. So once the patient screens positive, because they have that the high rates of heart rate, respiratory rate, temperature, the suspected infection, they are considered to have screened positive for sepsis, and the next step is the care and treatment, which is to get the blood culture, to do a lactate test, to start antibiotics, to give fluid resuscitation, and all those things, of course, will be happening much earlier if we get that screen positive earlier.
All right, just 1 second. So do you get paid if you take that blood test the first time and it doesn't come back with sepsis or gram-negative sepsis? Do they pay you for that?
That's a question for my colleague.
So currently, yes, if we get a sepsis diagnosis, the change that's being proposed is that sepsis diagnosis will be eliminated, and only when you had organ dysfunction and severe sepsis, that's the only time sepsis will be recognized and paid for at that point.
I've had patients where this minute they weren't, this minute they were. Thank you for your time. Thank you, Chair
Thank you,
Lady.
sir.
Yes, thank you. Representative Dotson.
Thank you, Madam Chair. From my own understanding, is there 4 stages of sepsis? Is that correct?
Well, that's a great question. The process of attempting to change the way we look at sepsis takes it from actually 3 to 2.
Okay.
And so really right now, the way that CMS looks at sepsis, and frankly all clinicians look at sepsis, is that you have an initial patient comes in, they have sepsis, not treated, it advances. I call it the runaway train. It proceeds to severe sepsis. If that's not taken care of and treated, to septic shock.
Follow up. The reason I'm asking is that, correct me if I'm wrong, but Medicare pays through every stage
Correct.
of sepsis, to whereas Medicaid does not. They want to wait till you get to the latter stage.
Correct.
So what we're trying to do here is to try to bring them in line with Medicaid, in line with Medicare.
Right.
Okay, thank you so much.
Representative Bratcher.
Can a tooth infection cause sepsis?
Yes. Any infection.
Thank you.
Okay. All right. Seeing no further questions, DJ, please take the roll.
Representative Bentley?
Yes.
Representative Bratcher?
Yes.
Representative Bray?
Yes.
Representative Burke?
Yes.
Representative Callaway? Representative Camille?
Yes.
Representative Dotson?
Yes.
Representative Duvall?
Yes.
Representative Frazier Gordon? Yes. Representative Justice? Representative Neighbors?
Yes.
Representative Rayburn?
Yes.
Representative Raymer?
Yes.
Representative Riley?
Yes.
Representative Rourks?
Yes.
Representative Sharp?
Aye.
Representative Wilner?
Yes.
Representative Whidden?
Yes. And I'd also like to register my attendance.
Representative Chair Mosier?
Yes. Okay. All right. House Bill 477 passes with unanimous favorability, and the same should pass on the House. Thank you so much for being here. Thank you for bringing this bill. Okay. Seeing no further business, I will entertain a motion to adjourn. We have a motion and a second. We are adjourned. The next meeting is February 29th at noon in the same room.